Ms Lewell, and it's a pleasure to serve under your chairmanship this afternoon. And can I congratulate the Honourable Lady Member for Reigate on securing this debate and the constructive tone in which she's engaged with myself and my department and the way she has led this debate. Our approach is governed by three principles. Firstly, that the health and well-being of children and young people is our primary concern, a point made by the Honourable Member for Strangford. Secondly, that evidence-led, effective, ethical and safe healthcare must be provided to all who need it when they need it, a point well made by my friend from Macclesfield. And thirdly, this government believes in the dignity and equality of every single one of His Majesty's citizens. Since the election, we have calmly and cautiously been guided by the evidence. We take children's healthcare extremely serious. This is why we remain committed to implementing the CAS review and ensuring that children and young people who are looking for support in relation to their gender receive the highest quality of care that one would expect of any other child health service in the NHS. Now,
Thank you. Dr Cass was clear in her review that the model of care for people with gender incongruence, particularly for children and young people, needs to be changed to take into account their holistic care needs. And can the Minister provide us with an update today on the progress being made by her department in implementing these findings?
I thank her for that, and I will absolutely, in my time, I hope I get on to that in my speech. It's really important that people are aware of that progress. Now, I know that many are concerned about the ethics of this research, as the Honourable Lady has raised, and the Honourable Member for South Holland and the Deepings. And I can assure members here present that the UK, as we know, has got extremely rigorous and robust ethical approvals pathways in place, that no clinical trial can proceed without having approved the necessary independent scientific approvals. We already use these processes regularly to consider clinical trials in children so that we can evaluate new treatments for a whole range of conditions, whether for cancer, depression, respiratory infections or any illness. And the methodology of this trial is still being looked at through many aspects, such as how long we will follow children for, how many children will be on the trial, and how the demographics of that trial is constructed. That is still to be confirmed and approved. I know many honourable members have asked about that today. All participations in the trial will also be part of the ongoing observational study. Following the decision by my own friend, the Secretary of State, on puberty blockers, which was based on the evidence, we needed to make sure that we got on with helping scientists, researchers and clinicians do their jobs. Now, some people have called on the government to stop those experts from pursuing this line of inquiry. We've heard that again today. They have argued that the decision to halt the sale and supply of puberty blockers should be the end of the matter, and young people should not have access to this medication come what may. This would be to ignore the distress and real experience of young people, and the government, has no doubt, would drive people towards possible illegal and underground routes and shutting off access of young people to the conversations and professionals the opportunity to pause and consider other options. Instead, we can do what Dr Cass suggests and set out a proper path to treatment which involves young people, their parents, clinicians and mental health professions, knowing they are on a path will reassure young people they are being taken seriously. This cautious approach they will have to work through before joining a trial means young people have access to support and counselling which may result in them deciding against joining a trial and pursuing a medical route. That is an approach entirely missing over recent years. We all agree that treatment should be offered based on the best available evidence, and clinical trials in the UK are considered to be the gold standard for evaluating healthcare interventions. The CAS review found that evidence base underpinning medical and non-medical interventions in this clinic area must be improved. That is why we have commissioned a Pathways programme of research, one aspect of which includes the world's first clinical trial designed to help us better understand the relative benefits and potential wider effects of the use of puberty blockers in affected children. We must look at the most appropriate medical and non-medical approaches to support physical, emotional and psychosocial health. That's why the trial forms just one component of a wider study and growing portfolio of research jointly hosted by NHS England. That includes looking at the experiences of the 9,000 adults who as children were cared for under a previous model of NHS care, which I know the Honourable Member for Reigate has described as a medical scandal. Dr Cass was clear in her review that both a clinical trial on puberty blockers and a data linkage study, which many honourable members have raised today, are important to improving the evidence base based on gender incongruence in children and young people. Now, regardless of individuals' views on the practices of the Tavistock, I hope we can all agree that learning from the experiences of those thousands of people who have accessed puberty blocks is important. It will provide different and separately valuable information to the clinical trial, but this data alone will not give the answer as to whether we should or should not consider routinely prescribing these drugs in the future or continue the ban indefinitely. The adult gender services have now committed to sharing their data, a point also raised by honourable members, and I do acknowledge that we need to move quickly, and I expect to be making progress on this soon. And we will consider all data that is relevant to puberty blockers, including from the adult gender clinics. As with all clinical research, the team leading the trial must ensure that approval is obtained from the regulatory authorities, including one of the Health Research Authority's independent ethics committees and the Medicine and Healthcare Products Regulatory Agencies. These are all standard steps where the research receives full scrutiny. Once approvals are granted, the study protocol will be finalised and published, and only then can the trial commence. And I'm not able to comment on any finer details of that today, but we will issue further updates when they are available, and I commit to keeping members updated. I can assure honourable members that entry into the trial will be guided by strict eligibility criteria. It will only involve young people under the care of NHS Children's Gender Services who have received a full assessment and where other appropriate forms of support have been offered and where their clinician supports are referable to the trial. Under the law, if a child is under 16, a parent will have to consent to their participation, and the child also needs to agree. I am repeating myself slightly, Chair, but this level of caution was entirely missing over recent years. This is a more considered and evidence-based approach. In the past, puberty blockers were presented as the magic pill young people needed to access. This trial will give children and young people the support they need to make major decisions. We are currently in a situation, we've heard that today, where some people think it's unethical not to provide these treatments and some think it's unethical to provide it. The reality is we don't have a definitive evidence. When this happens, we routinely ask for the study to be checked by an independent ethics committee, and then we spell out the uncertainty to young people and their parents so they can balance any risk around uncertainty against their desire to join the trial before deciding if they wish to participate or not. I'm sorry, I'm tight on time, I'm afraid. The uncertainty is common to many new treatments. In doing this, we will ensure that these treatments are no longer used in the absence of such evidence. During the trial, an independent committee checks whether new results emerge from other countries around the world, a point raised again in many questions. If evidence emerges that the benefits or risks are really clear, such that we could issue clinical guidelines based on those results, then the trial would be stopped. We need better quality evidence to support the NHS in providing reliable, transparent information and advice to support children and young people and their parents and carers in making important treatment decisions. And that's exactly what NHS England and the National Institute of Health and Care Research Programme is going to provide. If I may, Ms Lewell, just update, as I've been asked, on the CAS review implementation. Beyond this research, we are absolutely committed to implementing the CAS review. In fact, I'm not entirely sure what the Liberal Democrats' position, as we've heard this afternoon, is. But we are very clear. We will continue to work to do that, and we will continue to work in lockstep with NHS England to get it done. We have opened those 3 services. A 4th service in the east of England is planned this spring. These services operate under a fundamentally different clinical model, where children and young people get the tailored and holistic care they need from a multidisciplinary team of experts in paediatrics, neurodiversity and mental health. At first, these services were seeing patients transferred over from the now closed Gender Identity Development Service at the Tavistock, but now I'm pleased to say that all the services are taking patients from the national waiting list. NHS England aims for there to be a service in every region of England by 2026. This will help to reduce the waiting list and bring these services closer to the homes of the children and the young people who need them.